Good afternoon. Welcome to another UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. Welcome to our live audience, to our colleagues here at UCSF and in the Department of Medicine and throughout the institution, and through our partners in the UCSF Health Network. I see we already have about 700 people watching live, which is terrific. We're also videoing this and we'll post it later on YouTube. Our prior Grand Rounds have received a total of about 120,000 views, so it seems like we are filling a need, which we're quite pleased about. A few ground rules are here on the slide. You will put your Zoom window in full screen mode. That's for the best viewing. And if you have questions, type them in the Q&A. That's being monitored, and we'll talk through some of the questions during the discussion period after the first lectures. None of the speakers have any conflicts of interest. In today's Grand Rounds, we'll begin with 3 lectures. The first 2 will concern clinical aspects of COVID-19. One by Brian Schwartz from our Division of Infectious Disease. We'll talk about overall clinical aspects and things that we've learned in the last several weeks. And then Andy Josephson, who's the chair of our Department of Neurology, will focus on some of the neurological aspects that are becoming clearer. We'll then do a Q&A and then turn to Mike Reid, who's from our Division of Infectious Diseases, who will talk about contact tracing and what we've learned, what the science of contact tracing is, and some of the practical issues in contact tracing as that becomes a more important part of our approach. Then we'll shift at about 1 o'clock to a panel discussion that will go to probably about 1:35, maybe 1:40, and it will focus on the issues of COVID-19 in New York. We've been incredibly lucky here in San Francisco to have a relatively benign course. In New York, obviously, that has not been true, and the tragedies are heartbreaking. And we'll have 4 speakers who will address the experience in New York, including the Chief Medical Officer of New York Presbyterian's Queens Hospital, which has been one of the hardest hit hospitals, as well as 3 UCSF physicians who are helping out in New York. And as I said, that will go to about 1:40 or so. So let's go ahead and begin with Brian Schwartz. And Brian is Professor of Medicine in our Division of Infectious Diseases at UCSF Health. He's a spectacular clinician and teacher, one of our go-to people for all things ID. He's also Vice Chief for Clinical Affairs and runs our fellowship in infectious disease, and he will give an update on what we're learning about the clinical manifestations of COVID-19. Brian.
Thanks so much, Bob. It's really exciting to be here, and this is a really exciting time for science and infectious diseases. I frame my talk today on thinking about what we learned in the last week, which is amazing to think about a topic where I can fill up, I'm going to be doing 15 minutes, but I could probably easily fill up an hour about a week's worth of new data that's coming out. It can be a little challenging sometimes to figure out the signal from the noise, but hopefully we can look at some really interesting papers today together. Next slide, please. I'm going to take just a brief moment and do an epi update. I will pick a science paper focused more on epi, a little bit on clinical updates, 2 really interesting papers on diagnostics, and then finish with what I think is probably in a lot of people's mind after the remdesivir data came out yesterday, and share my thoughts on those trials. Next slide, please. So I will start it off with, I think, most COVID talks talking a little bit about the epidemiology. Worldwide, we have over 3 million cases with almost 250,000 deaths. In the US, we make up about 1/3 of the cases with over 60,000 deaths. In California, 46,000 cases with nearing 2,000 deaths. In San Francisco, we've still been relatively spared with 1,500 cases and only 23 deaths as of yesterday. I will then share some data at our 3 main hospitals. At UCSF Medical Center, we have 17 inpatients, 7 in the ICU. We've had 3 deaths to date. At Zuckerberg San Francisco General, they have 21 inpatients right now, 10 in the ICU, and have had 1 death. And at San Francisco VA Medical Center, they have presently 1 inpatient and have had 2 deaths so far. Next slide, please. Now, when thinking about, again, with all the data that is coming out, what should I focus on and to think about some science? And there have been really interesting studies looking at an understanding of when you get infected with SARS-CoV-2 going into the clinical manifestations and thinking about the immune response. But I thought I would focus on an epi paper today. Next slide, please. This study was published just last Friday, and it describes a focus around pre-symptomatic disease in patients who had COVID-19 in a skilled nursing facility in the state of Washington. This study, the investigators described this outbreak. It happened at the end of February, early March of 2020. And when they identified that there was an outbreak, they went around and did oropharyngeal and nasopharyngeal swabs for PCR and culture. And I do want to mention that the culture piece is really interesting because culture is a better marker of transmittability and infectiveness than PCR, and it has not been done in a lot of the studies to date. So they did those, did symptom recall and repeated it twice during that time. What did they find? Well, they found that of the patients tested, 63 of them were positive by PCR. Many of them were also culture positive, and 56% of them were asymptomatic at that initial time point. So which we're starting to learn more and more about how high asymptomatic disease is, but it was quite remarkable here in this case. They followed these patients over time, and of the 27 patients that were asymptomatic, 89% of them went on to develop clinical disease. And sadly, at this skilled nursing facility, where we had an older population with a lot of comorbidities, the mortality rate there was 26%. So a lot of symptomatic patients, high mortality rate. And I pulled out this one figure from the study, which I thought was quite interesting to see. If you look at the pink line that I've put in, that is the first onset of symptoms. And the negative numbers are prior to. And you can see that as far back as 6 days before the onset of symptoms, patients were culture positive, really suggesting that probably for many, many days prior to developing symptoms, that these patients are able to transmit infection. Next slide, please. So some of my colleagues, Dr. Monica Gandhi, Dr. Deborah Yokoe, and Dr. Diane Havler wrote an outstanding editorial with this paper in the New England Journal of Medicine. And again, considering how many people were asymptomatic, or what we actually figured out was pre-symptomatic, and how high the mortality was, they made some really, I think, clear and helpful recommendations to prevent this from happening in the future. They recommended regular testing and retesting of all skilled nursing facility patients, universal masking of healthcare workers at skilled nursing facilities, regular testing and retesting of the healthcare workers there, and that considering what we found in a skilled nursing facility, that there probably are other congregate living situations where we could have high mortality, morbidity, and those might be prisons and jails, enclosed mental health facilities, homeless shelters, and even in hospitalized patients. Next slide, please. A little bit now about a clinical update. Next slide, please. My colleague, Jennifer Babick, has done an amazing job over the last month or so providing clinical updates at this forum and through UCSF Medical Center. And she's described a myriad of different clinical symptoms that we see. Patients have ocular symptoms, they have issues with smell and taste, asymptomatic findings on a chest CT to developing ARDS, cardiac disease, GI manifestations, including diarrhea, nausea, and vomiting, transaminitis, low lymphocyte counts, and then having myalgias and fevers, all the way to having a tremendous explosion of their inflammatory response, causing shock. A couple new things have happened since she last spoke that I'll bring up. One of them is around the noticing increased rates of thrombosis. Now, whether this is truly related to COVID-19, or is this related to patients who have critical illness and ARDS with infection, I think it still remains to be seen, but there definitely have been reports of a lot of patients with pulmonary embolism and other types of thrombotic events. Dr. Andy Josephson will be speaking after me about neurological manifestations, and he will be talking about stroke as well. I take a second and just talk about skin manifestations of COVID-19, because there's been some data that have come out recently. Next slide, please. So what are the cutaneous manifestations of COVID-19? So if you look at large studies, rash has been reported in less than 1 to 20% of patients with COVID-19 and have been described in lots of different flavors. They've described erythematous rashes, urticarial reactions, vesicular rashes that look like zoster or chickenpox, and then acral lesions, both ischemic and ecchymotic, and patients, again, who are symptomatic and have COVID-19 clearly. There have now been some reports both in Europe and here in the US of some asymptomatic, often younger patients that have acroischemic toe lesions. And then I've shared some images for some of these papers that you can see. Some of them are purplish lesions, some of them are vesicular, and some are duskiness of the toes. What's interesting here is that in the studies, many of the patients did not have positive PCR for COVID. Some of it was just due to lack of testing. But whether there's a true correlation with these lesions in COVID-19 and whether this is related to thrombosis, whether these are antigen antibody depositions and it's immune mediated reaction or it's viral disease alone, I think still remains to be seen. I think my take home from seeing these is that when you see patients with lesions like this, you may consider doing COVID-19 PCR screening at least to start, and think about precautions as you would for other people who you're concerned. Next slide, please. I'm now going to move on to talking about some really exciting diagnostic studies. Next slide, please. So I think everybody has probably heard about the rollout of COVID-19 serology tests. And I think in a lot of different forums this has been discussed, but I thought I'd take 1 second to just make sure we're all on the same page. Serologies are antibody tests, seeing the body's immune response to infection, whereas when we talk about PCR, we're talking about nucleic acid or detection of viral particles itself. The FDA had allowed some restrictions in the developments of these serological tests, and many have been coming out recently. The feeling is that serology probably is most useful for the diagnosis of COVID-19 a little bit later in disease when you see the PCR levels coming down and you may have increasing in a serological response. They could be used in epidemiological surveys. It can be used to identify who might be a good candidate to donate for convalescent plasma or serum. And then ultimately, when we get a vaccine, using serology will help to identify who had a serological response. One of the questions that still remains is a positive IgG test here correlated with immunity, and this is still unknown. Next slide, please. So I wanted to highlight a preprint, so this is not a peer-reviewed study yet, done by one of our colleagues here at UCSF, Dr. Alex Marson, and in collaboration with many people. Given that there were many tests coming out and the rigor that the FDA usually supports for these was a little bit different, they did a heroic effort of wanting to evaluate 10 lateral flow assays and 2 ELISAs that look for IgM and IgG for patients with COVID-19. They looked at samples. There were positive controls, 130 from patients who had known COVID-19, and then negative controls were either prior to the COVID-19 era or with patients who had diagnosed with other respiratory illness. The sensitivity for the IgG increased over time, and on my screen here, it is coming off a bit unusual. But on yours, you may be able to see it that over time that there is an increase in the sensitivity of the test, and it gets as high as 81 to 100% depending on the assay when you're greater than 20 days of after having the onset of symptoms. The specificity was reported depending on the assay at 84 to 100%. A couple other key takeaways that I learned from their work was that when you did a combination of IgM and IgG, the sensitivity may be a little bit greater. And that also that patients who had there was a trend for people who had more mild disease that you may have had less seroconversion. The other thing that I do want to highlight is remember that in a low prevalence population, and I think George Rutherford's done a nice job of highlighting this over and over again, that you really want tests that have very, very high specificity. And if you're using tests with lower specificity, you're going to get a lot of false positives, and it's going to give you incorrect data. Next slide, please. The other study that I wanted to touch on in terms of diagnostics was another preprint that just came out this week. So not peer reviewed, that looked at PCR of saliva for the diagnosis of COVID-19. They took 44 inpatients who had COVID-19, and they did serial PCR for nasopharyngeal swabs, but they collected saliva. So how did they do that? So in the morning when the patient woke up, they gave them a sterile urine cup, and they had them spit in the cup until it was half full. And then they analyzed both the saliva and the NP swabs. And if you can look in the figure here, that the viral load was higher on average in the saliva than it was in the nasopharyngeal swabs. They also looked at this longitudinally with repeat testing, and they found less variability in positivity over time, and it stayed positive as long as nasopharyngeal swabs. So why do we even bring this up? Why is this important? Well, as you're going to hear from Dr. Reid a little bit later, is that we're working really hard to try to find ways to identify patients in the community, test them, isolate them. And if you have self-collection methods that are easy and effective, that this could be a really useful tool. So the other issue is that we are having swab shortages, and this technique excludes swabs. So for both of these reasons, this may be a really exciting way to diagnose COVID-19 moving forward. Next slide, please. The last thing that I'm going to talk about is therapeutics. Next slide, please. Now, if you look worldwide in the COVID-19 epidemic, there are numerous different treatments that are being used and being studied quite rigorously. There are antiviral medications, there are immune modulators that more suppress the immune system, there are those that may enhance the immune system, and there are a lot of different ways that people are approaching treatment. Next slide, please. Just yesterday, there were 3 different publications, one in the Lancet and 2 that were press releases, which I'll go into, that talked about remdesivir. So for those of you that are not familiar with remdesivir, it is an antiviral medication that inhibits viral RNA polymerase and inhibits viral replication. It is only administered intravenously, so mostly used in hospitalized patients. And to date, there were in vitro data that were supportive of efficacy. And recently, there was actually a monkey model study that showed both clinical, radiographic, and virological benefit. And given this, there have been studies that are supported by the National Institutes of Allergy and Infectious Diseases, and as well as Gilead, to look at the effectiveness of remdesivir in the treatment of patients with COVID-19. Next slide, please. As I mentioned, just yesterday, there were 3 different studies that came out describing treatment with COVID-19, for COVID-19 with remdesivir. The first study, it was published in the Lancet. It was done in China, and they compared remdesivir 10 days versus placebo, and the primary endpoint was clinical improvement. Now, unfortunately, or you could say fortunately, they were only able to enroll 237 of their goal of 453 patients. The reason this study was stopped early was because they had gotten the epidemic of COVID-19 under control in China, and there were just fewer patients to enroll. Therefore, this study was very underpowered, but they did not show any difference in clinical outcomes, death, or viral load in patients who had received treatment with remdesivir versus placebo. There was a trend for patients who had had symptoms for less than 10 days when they received treatment to potentially have better outcomes. But again, this was a trend. Probably the most exciting of these 3 is the NIH randomized controlled trial called ACT-1. This was provided, we were provided information via a press release. And this was, again, very similar to the Chinese study where they used remdesivir for 10 days versus placebo, and their primary endpoint was clinical improvement. They have enrolled over 1,000 patients, and they provided some interim analysis here. And what they shared was that the time to recovery, or their primary endpoint, in patients who received remdesivir was only 11 days versus those who had a placebo was 15 days, which they report is 31% faster and statistically significant. The only other piece of data they shared was around mortality, and it suggested that it is not at this point statistically significant, but that those who received remdesivir had a mortality of 8% versus 11.6 in the placebo group. They report that over the next couple weeks, we should be getting more data. The last one I'll mention is one that was specifically in patients with severe disease, and the study design was very different. It was an open label study that compared 5 days of remdesivir versus 10 days. And what they found was that the overall outcomes in these patients were the same, but similar, as we saw in the Chinese study, there was a trend to improved outcomes if remdesivir was started less than 10 days since symptom onset. So altogether, this is really exciting and suggestive that we may have now a drug that is effective for patients with COVID-19. That being said, we would really like to see all the data, and we have very little available at this time. Next slide, please. So what are we doing here at UCSF? So I want to highlight four, although there are many people working on this. Annie Lukemeyer, in partnership with Michael Mathey, is leading an interventional studies for COVID-19 work group. And this group is looking at different treatment trials and helping us decide at our institutions which ones we should be considering. Dr. Lukemeyer is also leading the clinical trials at San Francisco General. Sarah Dorenberg is leading the NIAID adaptive trial here at UCSF, and Peter Chin Hong has been leading our ability to get remdesivir and convalescent serum through early access programs. So what are we doing here? So the NIAID adaptive trial in phase 1, which was remdesivir versus control, is now closed. The feeling is, given that the positive data that we have seen, that it will likely then turn to remdesivir versus remdesivir plus baricitinib, which is a JAK inhibitor. We also have studies ongoing using mesenchymal stromal cells, which Dr. Mathey is leading. And there is a study in the outpatient setting looking at colchicine versus placebo, which is led by Priscilla Hsu at San Francisco General Hospital. There are early access programs with remdesivir, as I mentioned, and I imagine, and there are suggestions out in the press, that given the positive remdesivir data, that very soon it will become a lot easier to access that drug. And we also have convalescent sera available. What I have here in blue are some of the studies that may be coming online in the future. Again, there are a lot of folks working very hard to get these organized, but they're both inpatient and outpatient studies looking at hydroxychloroquine versus control, convalescent serum versus control, and canakinumab, which is an anti-IL-1B monoclonal antibody versus control. And with that, I will conclude. Thank you.
Thank you, Brian. That was terrific, and it really is a fire hose, an amazing amount of information in just a short period of time. Let's turn to Andy to stick with the theme of clinical manifestations. So Andy Josephson's chair of our Department of Neurology. He helped pioneer the neurohospitalist field. He specializes in difficult to diagnose inpatient neurologic conditions. He's also editor of the journal JAMA Neurology. And Andy will give us an update on what we're learning about COVID in the nervous system.
Well, thanks, Bob. Thanks a lot for having me. I'm going to talk, as you asked, about this story that's emerged in the last few weeks regarding COVID-19 and the nervous system. It's a study and a story that I think has been leading to many more questions than answers, but an interesting one nonetheless. Next slide, please. This article was published just 3 weeks ago in JAMA Neurology, and it was the first series really looking at neurologic manifestations of hospitalized patients with COVID-19 in Wuhan. Next slide, please. This retrospective observational case series involved 3 different COVID-19 focused hospitals in Wuhan, 214 consecutive patients with a mean age of 53 years. Now, 40% of these individuals had severe disease, but the disease severity was only defined by respiratory status. Next, please. And the headline, which really was interesting and I think surprising for many of us, was that over 1/3 of these patients were found to have neurologic manifestations. And these were much more common in those with more severe infections. So let's dive into this a little more. Next slide, please. Here's a table describing the neurologic manifestations that were reported, the total number, and the breakdown between these manifestations in severe and non-severe disease. Next, please. If we concentrate on the central nervous system manifestations, you'll see some of these are relatively non-specific, like dizziness and headache. But there was a 7.5% of these folks had some sort of impaired consciousness, whether that was delirium, confusion, or cognitive problems not otherwise specified, we don't know. And 6 of these individuals, 5 with severe disease, had an acute stroke. Now, there were peripheral nervous manifestations as well described, the taste and smell abnormalities that I think we're all familiar with, that I'll talk about a little later, as well as patients with nerve pain, and about 1 out of 10 that had, quote, skeletal muscle injury, as defined by muscle soreness and an elevated CK in the serum. Next slide, please. Now, this has also been brought to light and really focused the press and national attention by a recent report, just a short letter, a correspondence in the New England Journal of Medicine, wondering about stroke and focusing on stroke in young people with COVID-19. This was a single system report in New York City of only 5 patients who were less than 50 years old, who over a 2-week period presented with a large vessel ischemic stroke. Now, all of these individuals ended up testing positive for COVID. And remember, this is in New York with a higher prevalence than we have here in San Francisco. But of these individuals, 3 had only mild symptoms and 2 were relatively asymptomatic. To put this in context, this particular healthcare system in New York averages about 20 such young people with large vessel strokes every year. So in a 2-week period, they would have expected to see 1. Instead, they saw 5. Again, not great detail, a small report, but at least something that piques our interest. 3 of these individuals had underlying vascular risk factors, including 1 who had a stroke previously. We know essentially nothing in this short format regarding the workup for the etiology of stroke in these patients. We don't know what was done. We don't know what was concluded as to why these strokes occurred, but there is some discussion as to whether or not this represents those thromboses, hypercoagulability that Brian described that has been well described otherwise in COVID-19. We can also think of many other reasons why patients with COVID might have stroke. The cardiac manifestations may lead to arrhythmia or a clot in the setting of a cardiomyopathy. People who, especially young people who are coughing a lot, can develop a cervical artery dissection. There's just more to learn, but I think the overall feeling is that we have to understand more about the increased risk of stroke in COVID patients. Next slide, please. Now, there's some important caveats to all of this data. I mean, first of all, many of you recognize that some of these symptoms are very common in patients with severe viral syndromes, people with pneumonia, just people who are sick in the intensive care unit. They include things like impaired consciousness, headache, and dizziness that we see all the time. In the ICU, we blame medications, ICU delirium, which is so common, and then a question whether some of this is due to a cytokine storm systemically or a, quote, septic encephalopathy, which is ill-defined but has been described in these types of systemic illnesses all the time. Next, please. We also remember that muscle pain and CK elevation is very common in patients with influenza and other viral illnesses. And as I mentioned with stroke, we can think of many instances that these symptoms may not be specific for the CNS, but rather would be neurologic symptoms in reaction to systemic disease. Next, please. 2 weeks ago, there was a nice series published in the New England Journal of Medicine of 58 patients in France with severe disease, defined as ARDS in the ICU. Most of these patients were on sedation, although those who were paralyzed were excluded. Next, please. And this series as well showed us a lot of neurologic signs, including delirium, as noted by positive findings on the CAM ICU screen, agitation, corticospinal tract signs, and a more subtle cognitive dysexecutive syndrome, if you will. 3 of these patients, 25%, who were imaged, were found to have an ischemic stroke. Next, please. But I think this is particularly important when we start talking about what's going on in the spinal fluid. So 7 of these patients received CSF analysis, had a lumbar puncture. None of them were found to have hard signs of inflammation, pleocytosis, unique oligoclonal bands, or an elevated IG index. They didn't see this. And in all 7, they tested the spinal fluid for SARS-CoV-2 and were unable to detect it via PCR. Next slide, please. Now, we have been inundated in neurology with numerous other small series or just case reports, and it's hard to know how much weight to put on these. There have been a couple different series looking at Guillain-Barré in these patients, including 5 individuals who were published in the New England Journal of Medicine. There was a single case of acute hemorrhagic necrotizing encephalopathy published in Radiology, and you can see the images here. Question, is this a post-infectious CNS manifestation? But despite looking at all of these series, we really haven't seen any convincing cases of meningitis or encephalitis caused by the virus itself. Next, please. So the question comes up, which I think is rather important. Is there direct CNS involvement by the virus? Well, as we've talked about, smell issues have been clearly documented in multiple series, not just in people who have severe COVID infection, but in asymptomatic patients and in, as Brian termed, pre-symptomatic patients as a first manifestation of the illness. We don't yet understand this pathophysiology, but many people think that this is due to direct viral inflammation and direct viral involvement of the olfactory epithelium, which of course is right on the doorstep, if you will, of the CNS, suggesting that the virus is getting close to invading the brain, if not direct involvement. There was this rare report, a single report of brainstem involvement of the virus on a postmortem study. This has been described with other coronaviruses and has led to a lot of speculation. Oh, if the brainstem is involved, does that mean that there's involvement of the medullary respiratory centers? Does that somehow explain the high incidence of ventilatory failure that we see in these folks? I think speculative at this point, but something that needs to be explored further. But there's really not been, in a reasonably sized series, convincing isolation of the virus in the CSF. Next, please. When we think of the peripheral nervous system, well, this makes a little bit more sense. COVID-19 Guillain-Barré cases, as we talked about, have not shown a pleocytosis in their CSF, suggesting that this would be one of the more typical post-infectious Guillain-Barré cases, if it's related to the virus at all. We have a number of lessons from the initial SARS outbreak a decade ago that help us here. In the SARS outbreak, there were limited reports of neurologic syndromes, usually those that occurred 2 to 3 weeks into the illness, but they were much more peripheral nervous system focused rather than a central nervous system focus, related to mainly critical illness or a vasculitis of striated muscle. Next, please. And I'll finish by talking about sort of what I think are the key questions to be answered regarding neurologic manifestations. First, we've got to understand better the frequency of these neurologic complications in large, well-characterized series, including those that have neuroimaging, neurophysiology, that includes EMG, EEG, pathology, and then we need long-term follow-up with detailed cognitive testing to figure out how these patients do when they recover. I think it will be incredibly important to understand the actual CNS involvement by this virus if it does occur, and we would do that via biopsy specimens, post-mortem studies, or more detailed CSF studies. Now, looking at PCR in the CSF, we don't understand its sensitivity, and there's a lot of people worldwide, including Michael Wilson at our institution, who are looking at more novel ways to look for the virus or its antibodies in the CSF. And then finally, I would just say that we have to understand the mechanism and pathophysiology of these neurologic complications. If indeed this is caused by viral infiltration in the CNS, and I don't think we have any data that it is yet, that has broad-ranging implications, for instance, for treatment. If we're going to develop therapies, then we need to make sure that those therapies, if that's the case, cross the blood-brain barrier and are able to hurt the virus, help the virus go away in an immune-privileged place, i.e. the CNS. This would also have, obviously, important manifestations and important implications for people who might have symptoms that are long-lasting in the nervous system following resolution of COVID infection. So that's what I wanted to cover. Back to you, Bob. Again, thank you very much for having me.
Thank you, Andy. That was terrific. So maybe one quick question for you then. Most of the questions that came in were for Brian. This is your role as both neurologist and journal editor. 5-patient series makes it into the New England Journal. How do we think about that? I mean, in some ways, everybody is so interested. This is all new. We're trying to learn. On the other hand, there always is the possibility that it's just too small a series to make much out of. How do you think about that in your editorial role and when you read it?
Yeah, it's a great question, Bob. I think most of us who are editors of journals have been just inundated with multiple publications, many of which are, I once saw a case of, or here's a small series of these patients. And you have to walk this balancing act, as you're alluding to, of getting information out to the public that might help clinicians, but making sure we're not making too much of a big deal of a little blip, especially in areas where the prevalence is very high. I mean, if the prevalence is high in an area like New York City, then almost any condition that occurs, a broken leg, if you will, you could say is associated with COVID-19. So I think one has to be very cautious and walk that balancing act so that we're informing our medical community and the public while being particularly judicious that we're only publishing things that we really think are important and could be game changing.
Okay, a lot of questions for Brian. So, and we probably have about 7-ish minutes to try to get through as many as we can. So the whole issue of asymptomatic and pre-symptomatic disease, which is one of the superpowers, I guess, of this virus. Are they as infectious during that stage as they are when they're sicker? And are they as likely to generate antibodies when they get better?
So in terms of infectivity, I think from everything that we have seen so far, our assumption should be is that they are as infective as somebody who does not have, as somebody who has symptoms early on, and they should be treated in that way. In terms of antibody production, there was in Alex Marson's paper, there was some suggestion that if you had less significant clinical disease, that you may be less likely to generate an antibody response, but I don't think it was statistically significant, and it was a trend, and I imagine we'll be seeing more around that idea in the future.
And we hear all of these caveats that we don't know for sure that antibodies are associated with immunity. But wouldn't you think in New York or Italy or whatever other place that if they were not, we'd be hearing about boatloads of people who had COVID, left the hospital, and came back again with another episode of COVID, which I don't think we've heard?
I agree with you, Bob. I think that the odds are that you do have immunity. I think that us being scientists and trying to be dot I's and cross T's just don't know for sure at this point. But I agree. I think that at least it's likely that you have immunity. I think the second question that comes up is how long. If you look at other coronaviruses, human coronaviruses out there that cause URIs, it's not felt that immunity is lifelong. So I think that'll be interesting thing for us to also better understand.
Now that we understand better the issue of asymptomatic infection or pre-symptomatic infection, does temperature checking make any sense? There are all sorts of strategies that relate to people firing some little temperature checker at your forehead. Does that make any sense at all?
It certainly seems like using that alone would not be the best strategy. I agree. It seems like a much less useful strategy, and that testing really would be the most important way.
So let's get on to testing. So given what we know about the viral testing and we know about serologic testing and the flaws in the testing and the tests so far, how are you processing this in terms of a rational testing strategy? And some of the questions that came up were around very specific populations. Like we hear about certain healthcare organizations that are beginning to test every healthcare worker. We're getting patients coming into the clinic who are saying, I had COVID last month, which of course in San Francisco, we have no idea, and they probably didn't given the prevalence, but I had symptoms I think are COVID. I need to be tested for antibodies. So how do you come up with sort of a rational plan for all of these different populations given these different test characteristics?
I will start with the caveat that there is a very thoughtful group both in the infection control and the clinical leadership of the COVID programs here that are working on continuing to give more guidance. I think at this time, there's no reason to say that you can't have somebody get serological testing if they think they had it before. I think what to remind them is if they get sick again, they're still going to have to come in for PCR testing, and it's hard. I'm not sure how it's going to probably reduce their anxiety to some degree, but I'm not sure how it's necessarily at this point going to change the way that you care for that patient or recommendations you're going to make.
And also just to say that unless the test is perfectly specific, if they have a positive, there's some chance it's a false positive, right?
Absolutely, and there's sensitivity issues as well. If you looked at Marston's paper, it was the sensitivity is not 100% in a lot of those tests also. So great point.
And then in terms of testing populations like healthcare workers, I guess, it tells you, assuming you believe the test, that you're not infected or you don't have the disease today. Doesn't really tell you a lot about whether you have it next week. So how do we think about those tests?
So I agree that a single test in time in a healthcare worker is probably not that helpful. And that if you do testing, that you would imagine that it would have to be something where you're going to repeat testing. Doctors Sarah Dorenberg and Vivek Jain, in working with the Chan Zuckerberg BioHub, actually got a large grant looking at healthcare workers and a project where they're going to be doing repeat testing both here in Stanford. So I think there'll be more to follow in the future about that.
But what would be, just from what we know about the virus, what would be the right periodicity? So if, let's assume the test is easy to get, cheap, and we say we want to test all healthcare workers. Do I need to get it every 3 days, 5 days, 2 weeks? What's the right, what's the right periodicity?
It's a great question. I think something in the range of probably 3 days to a week feels right. I mean, it's gonna be hard to get it perfect. You probably, if you did it every 2 or 3 days, you can get near to 100%. But is that practical? And can we do point of care on that many people? It's going to be a balance.
And we're all spitting into urine cups every morning. And maybe both, the last one to both of you, given what we're beginning to learn about hypercoagulability, and I spoke to one of our nephrology colleagues the other day who said that the filters are clotting off in ways that he had never seen before. First of all, is it real? And second of all, would you expect that it would be both on the venous and arterial side? Because obviously the PEs imply it's the venous side, and the strokes, if they're real, would imply it's on the arterial side. So maybe Brian start, and maybe Andy can comment as well.
Oh, I'll defer to Andy on this one. I don't know if I have a real thoughtful answer here.
Okay, Andy?
Yeah, I mean, the only thing I'd say from a cerebral vascular standpoint is exactly what you're alluding to, that I'm a little surprised that what we didn't hear about is that you have a lot of cerebral venous sinus thrombosis. We think of strokes on the venous side as being more common when people have, a lot of PEs and a lot of DVTs, but of course, in things like DIC and other real hypercoagulable states systemically, we see strokes as well. It's why I still wonder how many of these strokes are due to hypercoagulability versus, cardioembolic disease, which we know is occurring in some of these patients.
Great. Thank you both. It was terrific and exciting and amazing. And that's all just in the last week, what we've learned. Okay, let's move on to Mike. Thanks.
Thank you.
Mike Reid is Assistant Professor of Medicine in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General. He's involved in policy and agenda setting activities around improving care delivery for all sorts of patients with different infectious diseases, but I imagine most of his attention is now focused on one particular infectious disease, and he really has become our go-to person for contact tracing efforts in the Bay Area and increasingly throughout the state. So Mike.
Thanks, Bob. Thanks so much for having me. Great to be with you today. Next slide. I'm curious what you were all doing 2 months ago. I was writing papers on TB financing, scrambling to get my kids into summer camps and planning for an August vacation. And that all feels like a decade ago. The last 6 weeks, I've been working with San Francisco Department of Public Health, helping them to implement their contact tracing program. And before I describe what we've done, I just wanted to pause and reflect on just what a phenomenal job the leadership in the San Francisco's Department of Public Health have done. I want to give a shout out to Thomas Aragon, Susan Phillip, and my close collaborator, Darpan Sachdev, who have really demonstrated decisive leadership and visionary decision making in this moment. And as a San Francisco citizen, I'm especially grateful for their work. Next slide. So the big question I feel like everybody is asking is when can we move beyond shelter in place, right? And I think everybody is familiar with the kinds of things that need to be addressed if and when we're able to move safely into a point where we can resume some kind of new normal. So firstly, you know, as has been previously discussed in this venue, we need to see a drop in cases. We need to ensure that our health system is able to respond appropriately, and we need to have the public health capacity to test patients and trace contacts. And so I think, you know, the piece of work where I've been mostly involved is helping to think through when are we going to be ready for that place in terms of being able to diagnose, test, and then importantly, trace all of the contacts of individuals that are suffering from COVID-19. And that's the piece that I'm going to spend some time describing. Next slide. So contact tracing is not a new thing. It's a part of a public health response to many diseases, whether it's smallpox back in the 18th century, TB, syphilis, or HIV. And basically, just to summarize what we do, the first thing that happens when we see an individual who's suffering from COVID-19, one of the Department of Public Health's team gets on the phone with them, does a detailed interview to try and determine when did they fall ill, who did they come into contact with during the time that they were symptomatic and for a couple of days before they developed symptoms, and who in particular did they interact with during that period of their illness. And then in the next phase, we want to try and reach out and locate those contacts of that individual so that they can be informed about the exposure, educated as to the risk that they may be at in terms of developing disease, and then resource with the things that they need in order that they can safely self-quarantine. I think there are many places around the world that have been doing this well over the last few weeks, and I just wanted to draw attention to a couple of different countries. Next slide. So this is a study that was published a couple of days ago in Lancet ID, highlighting the impact of contact tracing in Shenzhen, China. What they did in this study was that they compared individuals who presented for care with symptoms against a separate cohort of individuals who were contacted through the contact tracing program that had been instituted by the Center for Communicable Disease and Prevention in Shenzhen. And the key take-home message here was that compared to symptom surveillance only, those individuals that were reached through the contact tracing program were recommended to isolate earlier by a couple of days. And if they needed hospitalization, were recommended for hospitalization sooner. And clearly, if we think that this is a disease that rapidly transmits, truncating the time between when an individual is infectious and then isolates or quarantines is crucial. And I think what this study clearly shows is that contact tracing and isolation for those that fell ill reduced the time of transmission and had an impact on the reproductive rate, or the R0. Broader impact of this remains unclear given what Brian was saying about asymptomatic transmission, but I think nonetheless we can assume that contact tracing is going to be an important part of our public health response in the coming months. Next slide. And I think as we look to other countries and how they have scaled up contact tracing, I think there are some important lessons that we can learn. I just want to highlight for you 2 countries in Asia that have done a phenomenal job, but their approach has been somewhat different. In South Korea, their contact tracing program involves capturing all sorts of different data streams to inform when an individual fell ill, who did they come into contact with. So they even take data from individuals' credit card transactions, their bank transactions, as well as logging their GPS records on their cell phone in order to get a textured, granular understanding of where each individual went before they ended up being isolated. As the data shows, that has been effective. I would say that has been effective in concert with a massive scale up in testing capability. In Singapore, similarly, I think what we've learned over the last 2 or 3 weeks is that their contact tracing program was initially highly successful, and there was much press coverage about an app that the Singapore government developed in partnership with Google called Trace Together, which used a Bluetooth technology to alert individuals when they come into close proximity to other individuals who were suffering from COVID. If any of you read the New York Times this last week, you'll have noticed that there was an increase in cases in Singapore. And I think that reflects the fact that even in that setting where there was robust contact tracing capability, when you don't fix issues around overcrowding and in access to healthcare, you can still see transmission such as they did. Next slide. So as SFDPH, San Francisco Department of Public Health, started to think through how could they scale a program to do contact tracing, given the need to respond rapidly, we were faced with a few key questions that I thought would be interesting for me to answer for you. The first was, what kind of technology do we need in order to do this, recognizing that there are many people that are concerned about confidentiality and privacy. The second is, where do we get the people to do this? SFDPH staff are already all working 24 hours a day right now. Everybody has maxed the capacity. And in order to scale contact tracing, where are we going to mobilize those the additional human resources? If we're going to use people that aren't public health trained, aren't healthcare professionals, what kind of training do they need? And then fourthly, and I won't spend too much time on this, what are the implications for the individual? If we're reaching out to people saying, hey, you need to quarantine, how do we support them to do that? And so these are questions that we've tried to rapidly respond to over the last few weeks, and I'm going to give you some of the solutions that have been developed in San Francisco. Next slide. So firstly, technology. It was clear here in San Francisco that in order to scale contact tracing, we had to move rapidly beyond a paper-based data capture system. And we needed a system that could be scaled so that people could work remotely from home and allow us to expand the workforce of people beyond the Department of Public Health. As I said before, we also needed a platform that was easy enough to use, even if you weren't a public health professional and if you weren't particularly technologically savvy. And we needed this like yesterday. So the tool that has been brought on is developed by a company called Dept. Essentially, it's a case management tool. It's not a proximity tracking application, but what it does, it enables us to rapidly collect the relevant data on cases and contacts, and then push SMS reminders to those individual contacts so that they can be informed and do the right thing. Next slide. And this is a very simple high-level visualization of what that platform does for us. Essentially, what it does is it links those individuals that are suspected of having COVID and have a positive lab result within the DPH system to a case investigator who does that initial investigation, contact elicitation process, and then pushes digitally all the details on those individual contacts to the team that I help to run, the contact tracing team. And then we get on the phone and we reach out to each of those individual contacts and give them specific advice that I'll come to in a second. In addition, recognizing that sometimes there are outbreaks that happen in the community, in schools, in workplaces, the platform allows us to disseminate the relevant information to a group of people within the Department of Public Health that can reach out to those institutions and alert them to possible exposure, so that again we can reach a broader constituent of potentially exposed members of our community. Next slide. So one thing I want to make clear is that the solution that we're using is not a proximity tracking app. I think many of you are familiar with the partnership that Google and Apple have announced, stating that they're going to offer a technological solution so that we as end users, as members of society, will be able to voluntarily sign into a scenario where we would be able to share our data if and when we fell ill with COVID, and anybody that was in close proximity to us would be able to be alerted if during the time that we were symptomatic, our phone came into proximity with them. I want to say clearly, this is not a technology that we're using in San Francisco. And if it does have a role, and perhaps we can talk about this at the end, I think it has to be used in addition to the public health contact tracing intervention response. There's really going to be no replacement for the need for a large army of public health professionals that do this work. Next slide. So how big is the army? So in Wuhan, China, when they mobilized a workforce of contact tracers, they activated 9,000 healthcare workers to reach a population of 11 million people. And they had groups of teams of 5 working round the clock to reach out to tens of thousands of people every day to alert them to their potential exposure. And certainly, I think there is consensus that similarly in the US, if we're going to do contact tracing at scale, we need to massively expand the force of that can do this. Tom Frieden, the ex-CDC director, estimates that we need 300,000 contact tracers across the US. Maybe in California, we need between 20 and 30,000 people doing case investigation and contact tracing. So just back of the envelope, how many contact tracers do we need in San Francisco right now? Well, you know, if we assume that right now we're seeing approximately 3 to 4 contacts per case, and each contact tracer is able to reach 2 to 3 contacts a day, an hour rather, then that's a relatively small number right now. But if we're imagining as we move beyond shelter in place that the number of contacts that everybody comes into contact with is going to double, and there might be spikes in incidents, then clearly the number of contact tracers that we will similarly need to scale. And our best estimate, and it's a guesstimate as much as anything, is that we need a workforce of between 100 and 150 people doing this, or being available to do this and being available to surge when there is an incident spike in the coming months, if we're able to move beyond shelter in place. Next slide. So in order to mobilize that army, we also have to train that army of people to do this. And as I mentioned earlier, right now, the Department of Public Health is fully activated. People are working long hours. So a question was raised a few weeks ago, where are we gonna find this human resource from? Well, the good news is that there are many people in San Francisco that are underworking right now because of shelter in place. And so the Department of Public Health reached out to colleagues within the city attorney's office and within the public library system and asked for volunteers. And truly, we were overwhelmed with willing volunteers. In the last couple of weeks, we've oriented over 400 people to contact tracing, and we've trained in depth with a 20-hour training program, 250 contact tracers. And as of this week, we're onboarding about 100 new tracers, in addition to a small team from UCSF that have been doing this for the last 3 weeks. So we have city attorneys, librarians, assessors, as well as an amazing group of medical students from the School of Medicine. What are they learning about? Well, as I said before, this is a community of people that probably didn't know much public health before this all started. We're teaching them the basics of public health, COVID 101, how to do contact tracing, what are the structural competencies you need to do contact tracing, how can you do patient-centered or client-centered interviewing when you've never done this before. We teach them with role plays, and then we obviously make sure that they understand the need to practice HIPAA compliant interview techniques, etc. And I think what we're finding is that it's a labor-intensive process, but if you want to have high-quality contact tracers, you not only need to train them, but you need to mentor them and support them over the period when they start work. Next slide. So how do we do this? Well, just sort of so that you can all imagine what's happening. It's really not that sexy. Essentially, we have a team lead. These are folks from the Institute from Global Health Sciences that I've been working with for the last 3 weeks. Phenomenal group of people who are leading small teams of contact tracers. Right now, there are 2 shifts undergo. They're teams of 5 people who are on their phones at home, reaching out to contacts using that Dimaji platform that I said before. And every team is supported by a clinician who is available on hand to help sort through some of the clinical issues that may arise. In brief, when anybody makes a phone call, what they do is they get on the phone, they say, hey, we understand that you came into contact with somebody who's suffering with COVID-19. We'd like to give you some information, educate you, and inform you of some things that are important to your own health as well as the health of our community. Would you mind giving us 20 minutes of your time? We take down some of their demographic information. I want to make the point that we're not taking down any information about their immigration status, their social security numbers, or their bank details. What we do want to know is if any of those individuals are symptomatic right now, and are they safe and well. In addition, we ask them, are they able to safely self-quarantine for the next 14 days if they don't have symptoms and need to be attended to straight away? And we recognize that in order to do that, they need supportive services. And then we give everybody a 14-day SMS repeat message that they can feed back to us if they have any symptoms at any point. Next slide. So I'm not going to spend any time going through the data, except that over the coming weeks, we will rigorously interrogate the data to ensure that we're showing impact. Next slide. I think there are some huge and exciting opportunities to think about how we can improve the efficiency of this work in terms of enhancing contact elicitation, training the workforce, and then linking people that are symptomatic to services as quickly as possible. Next slide. And I think if I had any closing thoughts, of first would be that there's no silver bullet here. Contact tracing only works as part of a robust, sophisticated public health response. The technology is intimately related to the implementation, and contact tracing only gets us half the way there. We need social support systems, particularly for the most vulnerable members of our community. Final slide. And I think the last thing to say is that it's clear that we need to rapidly scale our public health workforce, and I think UCSF can play a key role in that. I hope that we're going to be able to announce some really exciting initiatives at some point in the next 24 hours about how we're going to play a role to achieve that. But moving forward, I think UCSF and San Francisco are going to be a model for others in California and beyond about how we can do this effectively. Thanks, Bob.
Thank you, Mike. That's terrific talk and terrific to hear all the amazing things you're doing. Time maybe for a couple of questions. First of all, everybody wants to know how they can volunteer. So are you looking for people, or where do they go to a website, or let us know?
Thank you. Circle back with us. I am getting inundated on a daily basis with offers of volunteers. I think right now we're good, but maybe at some point in the coming weeks,
okay.
Yeah.
Tell me what a contact is. Someone has COVID and we were in the Safeway together. Am I a contact?
Yeah. So right now we're defining contacts as household contacts, any intimate partners, any other close contacts that you spent more than 10 minutes in close proximity to, less than 6 feet, or any time where you're exposed to secretions, snot, saliva from an individual that was confirmed to have COVID-19. Whether those individuals are people in the grocery store, I don't know. And I think, I think this is where there is real need to think about, are there more sophisticated ways for capturing that kind of information? We're not able to elicit that kind of information right now based on what we're doing.
Okay, and you made a point about the Google Apple tool, which of course got a lot of hype and interesting. I think the concerns about it have been around privacy, but also just the number of people that would have to sign on to this to make it meaningful, because you really need both the person who has the infection and all of the contacts to be on. So just walk us through that, and whether you're enthusiastic about it or somewhat skeptical about it.
I'm not a technophile, but like I want to lean into like innovation and recognize that we are a network society, right? And so if we can leverage this kind of information, we should think about how we can do that. But I do think you're right. I think there are reasons to pause. What does proximity mean if you're the other side of a perspex wall, or with where us, we actually lose proximity to each other? What are the implications of a positive alert for an individual? So somebody says my phone alerts that somebody came into close proximity to me. What do I do with that? You know, who's responsible for actioning on that information? I think that's why all of this has to happen within a public health response, where there's a public health intervention that can support you with the right information and resources if you are a contact.
Yeah, maybe the hardest thing that you said, as I think about all the steps, how do you get people to answer the phone?
Yeah, we send them an SMS in advance. We say, hey, we're from San Francisco Department of Public Health. We have an important message that we'd like to share with you. And we hope that people recognize that this is part of our shared responsibility as San Franciscans. If we're going to end this epidemic, we all have our part to play. And our hope is that we get that message out to everybody.
Great. Well, thank you for all you're doing to keep us safe, and we really appreciate it. Look forward to hearing that message in the next 24 hours. Thanks much. All right, let's bring on our panelists. And so let me introduce them as they're coming on. Amir Jaffer is the Chief Medical Officer of New York Presbyterian Queens. He's an old friend and a pioneering hospitalist. He's managing the COVID-19 surge at his hospital. He's known nationally for developing and implementing innovative, high-value clinical programs across patient populations, and I don't think that he thought this would become his job, but obviously it has. Sanjay Reddy is Associate Professor of Medicine in the Division of Hospital Medicine here, and also works in integrative medicine. Sanjay is one of, I think, about 25 UCSF clinicians who volunteered for and are now working in New York City, mostly at New York Presbyterian. They were chosen from more than 200 people who volunteered to do that, which is extraordinary. And so Sanjay's been there, I think, for now almost 2 weeks. We'll talk to him in a second. Alex Smith is Associate Professor of Medicine in our Division of Geriatrics. He is a prominent researcher who focuses on improving quality of care and communication with older patients, particularly those with a limited prognosis. And Carly Zapata is Assistant Professor of Medicine. She's in the Division of Palliative Medicine here at UCSF Health, and she attends on the Palliative Care Service and the Symptom Management Service. So thank you all for being here. And just to say, make clear, Alex and Carly's contribution has been through doing teleconsults in palliative care in New York. So we'll get to them in a few minutes. Let me start with Amir. So I remember now 2 months ago, we all felt like we were standing on a beach. We heard there's a tsunami coming. And here in San Francisco, we got some small little waves up to our knees, and you got the tsunami. So tell me about what the early days of this felt like, maybe even before it hit, what you thought might come, and then what happened when the tsunami hit.
Thank you, Bob. First and foremost, I want to thank you, Michelle Murad, and Dr. Adler for really helping organize this whole group from UCSF. Your critical care physicians, your hospitalists, the anesthesiologists and nurses have been phenomenal. They've had a major, major impact across our entire enterprise. And I can speak for Queens by saying that they've had a major impact. So thank you for that, and thank you for making it possible. Great presentations by Dr. Schwartz, Dr. Josephson, Dr. Reid, so thank you for your presentations. As you know, the first case that we had at our own hospital here was around March 8th. And I have to say, when we first started to have our initial cases, we really didn't know what lay ahead of us. And so we were just sort of trying to identify areas within the hospital where we were cohorting patients. And very quickly, the numbers picked up. So by around March 20th, we started to have over 50 admissions a day of patients who were positive. So our initial focus was really, as you know, on making sure that we had good testing platforms. And so we're lucky, we're part of a large enterprise, as you know, anchored by both Cornell and Columbia, 11 campuses. And so we worked very closely with the entire enterprise to make sure that we had at least some 2 core labs across the enterprise where we could very quickly start to do our own testing and not get stuck in the bottleneck from the Department of Health. So we focused on testing and then really preparing for surge capacity. But I have to tell you that we were really caught by surprise with the amount of surge that we had. If you think about the number of patients that we were having, over 50 and peaking at maybe about 90 a day that were COVID positive. You know, at one point we have a capacity in the hospital of 39 ICU beds. We had to triple them to about 112 ICU beds. Then you have to think about all the staffing to go along with that. And we were lucky that, you know, all elective surgery was canceled, ambulatory practices were canceled. So a lot of our physicians, advanced practice providers were redeployed from the outpatient setting, from the surgical arena, from anesthesia, et cetera, into the inpatient setting. But, you know, we had a massive challenge that lay ahead of us and that we were fighting on a daily basis. But I'm really proud of our teams. Our teams have just been phenomenal. You know, we had lots of challenges with nurses earlier on, but I would say that, you know, the physicians, the advanced practice providers, we've all sort of worked together as a team to deal with this massive challenge here.
Talk a little bit about that. It's extraordinary when I think about the numbers. You have 40 ICU beds and you need 120. Where do 80 more go?
Exactly. So, you know, we had to basically turn our PACUs. We have two major operating room areas. And so we basically converted those into ICU beds. In addition, we took a lot of our cardiac cath lab recovery area. We put ICUs in there. We converted all our cardiac ICUs into ICUs for COVID patients. And I would say at the peak, we had almost 105 vented patients, maybe a teeny bit more. Our numbers are now down closer to the late 90s. You know, the patients that are on vents, as you know, they've had much longer length of stay in the hospital, very high mortality. But with our patients that Sanjay has been managing on the hospice for us, their length of stay is also anywhere between 10 to 14 days. But we were able to sort of try to create capacity. We moved some of those patients to Javits, some of them to Comfort, and then we also worked with
Comfort in the boat.
Right. And then we also moved a large number of our patients to the hospital special surgery. They took some of our patients. So that's how we created general medicine capacity. And then on a daily basis, we'd move one or two of our really critically ill patients that needed ECMO, et cetera, to either Cornell or Columbia. And that also helped us.
People talk about you know, we all feared these wrenching ethical decisions. We do not have enough beds. We do not have enough ventilators. We have to choose between patient A and patient B. Did you get to that point?
No, we were very lucky, Bob. We did not get to that point. We were very, very close. We were very, very close. But, you know, we were able to organize a lot of vents for our patients. We also got the governor to support us, and, you know, from the government stockpiles, we got a lot of vents. We also, at some point, thought we were going to have challenges with our supply chain related to PPE, but luckily that did not bear out, and we've been very lucky on that front as well. We had some challenges with dialysate. Interestingly, as you know, a lot of these patients do get on CVVH, and so at one point we were facing a challenge with CVVH, but, you know, necessity is the mother of invention, as they say, and our nephrologists figured out ways to maybe do some peritoneal dialysis. You know, we actually looked to other organizations like Hopkins and Cleveland Clinic that had jerry-rigged their dialysis machines to produce dialysate. And so, you know, we were lucky. We came up with a lot of different innovations through this time that really helped sort of take care of a lot of these patients.
Well, Amir, as you say, we were lucky. There's very little that you've said that sounds lucky, but it's clear that you guys were incredibly resourceful, and you have our admiration for what you did. Maybe my last question for you right now, before I sort of move around. If you did not reach that point of this sort of wrenching ethical decision, what do you think is the hardest decision you had to make?
I think the hardest decision I remember was that we had almost 20 vented patients on outlying units, okay, being managed by general medicine nurses and doctors with just an outreach ICU service. We had created ICU capacity, but we didn't have nurses, okay? And I have to tell you that at some point, because we started off with, with only 39 beds, and our nurse staffing at our hospital is on the leaner side, we didn't have that many ICU nurses. So all of a sudden, you triple that capacity. So the toughest decision was telling our CNO that we were going to put all these vented patients in a unit with little or no nursing help, right? So that was very, very tough, because we literally had to tell Alan that we were going to do this because we thought it would be safer to have all our patients in that unit with very little nursing than leaving these patients all out on different units. I would say that for me, that was tough, because we had to really push Alan into embracing this decision that the physicians felt would be safer for patients.
Yeah, and just to get a sense of the human toll here, at UCSF, we've had 3 patients die. How many patients have you had die?
Very sad, almost 500. We've had, just to give you an idea, we've had over 2,000 admissions. Our mortality rate's around 27%. We've safely discharged over 1,500 patients, which is what we try our best to focus on, but we can't obviously just focus on that. We did have our 1,500 discharge yesterday, and we had a major sort of celebration for our teams, just to sort of create a positive vibe in the hospital. And we've been quite successful. We've just had amazing engagement from our teams, but we can't forget the lives that have been lost to this ferocious virus.
Yeah, and I assume including some of your healthcare workers?
Yes, we have definitely lost colleagues, healthcare workers from both our campus and other campuses across our system. And we had a nice memorial service for them, just to remember them and their contributions. So you're absolutely right. We have lost some amazing people through this. We continue to remember them and use that as a source of inspiration to really drive us every single day to focus in on what we're here to do for our patients.
Thank you for taking some time to talk to us, Amir. That's a remarkable story and amazing work that you have done.
Thank you.
Let me turn to Sanjay. So this is sort of running into the fire. What made you choose to do this?
I think, like a lot of people, it was nice that I was able to do it, and that everybody at UCSF was supportive of us all going over there. But it seems like this is the biggest event that's happened in my lifetime. And talking to a friend who's 89, it's the biggest event that's happened in his lifetime. And so to be able to help and participate in it, I think felt really important for me.
And you obviously had seen TV reports and probably spoke to colleagues and probably had some vision in your mind of what you were walking into. How was it compared to what you thought it would be?
So interestingly enough, New York started getting better just a few days before we arrived. I think we got there on Saturday, April 11th, and just a few days before, I think their increase in numbers started to slow down a little bit. So when we got there, it was still maybe 20 ventilated patients on the floor, and so I had a ventilated patient who was on the floor, which I haven't had before. But I think what was really
we've got a lot of viewers, particularly on YouTube later, who don't know how it works. So typically, when we have patients on ventilators, they're in the intensive care unit. They have one-to-one nursing support. It's an incredibly controlled environment. They're not on the regular hospital ward. So you walk down to the hospital ward, and there are 20 patients on ventilators on the hospital ward, which you had never taken care of at UCSF.
Which I've never seen before, and often in a shared room as well. And so not only was the nursing ratio different, but the room structure and everything was different too. And these aren't the ventilators that we're used to. These are portable ventilators that are little boxes without graphics too, a lot of times. And so, but I think the first thing that really struck us all when we got to New York Press Queens was was kind of what Amir was saying, just how amazing this team is, and how strong this team is to be able to pull through all of this. And for us, when we got there, it started to get better, but I think the strength to be able to go into work day after day when it kept getting worse and worse, and it was already the worst that you could have imagined or not even imagined. I think that strength and dedication is really remarkable. And Amir didn't talk about this, but he was hospitalized for 7 days with COVID, and returned to work while he was still dyspneic and needed oxygen. And I think you hear that a lot from a lot of the workers who were there. Not only did they know people who died, but they also got sick. And then we're still doing whatever they could to help support the teams there. And so I expected, as part of the toll that COVID took, I expected to see a bunch of broken and battered people. And I thought the providers were going to be kind of zombies and shells of humans at this point. And that's not what we saw at all. I think the camaraderie is incredibly strong there. And I think a lot of the support amongst their own community is part of how they've been able to pull through this. And people talking about how job descriptions went out the window. And you just hear some of the amazing stories of the work people have done. And then I think the other thing that's really remarkable is, despite all the amazing things that they've done, there's this huge sense of guilt, and this sadness of not being able to provide the best care that they wish they could have provided because the system was overwhelmed. And I think to give a better sense of what it would look like at Parnassus, it would be like if we suddenly we went from our winter that was already incredibly busy pre-COVID, and it was also for New York Press Queens, they were already pretty beat down after the winter pre-COVID. And if you went from our census then and then added 500 ICU patients that all had COVID and needed a ventilator every 2 to 3 weeks, that'll give you a better sense of what they were facing. But then if you add into things like your colleagues getting sick, and so you don't have your normal work staff, and a lot of your leaders getting sick, because the chief of pulmonary also had COVID pretty early on and was out for a while, and just kind of this continuous toll. And I think an added complication that I didn't realize before we got there is it turns out New York is one of the most litigious medical states in the country too. And so now you have all these people who are doing this amazing work, bending over backwards. I mean, really just going above and beyond. And now they're worried about getting sued for the lives that they've saved. And that's just, I mean, it's really hard to kind of describe how that must feel. And honestly, the strength just to show up every day, when this is a really easy time to fake being sick for 2 weeks, I think is difficult to underscore. And it's really amazing. And this team, just that they're still going strong, and we're so warm and welcoming to all of us, and really went out of their ways to make us feel like we're part of the team here. And so I'd like to show off my New York Press swag, but yeah, it's been really, really amazing to see just how strong these providers are and what they're capable of.
There was some concern when we were organizing this in the beginning of, like, how long will it take you guys to kind of figure the system out? Maybe different electronic health record and different the way they do the work. How long did it take?
So we got there on Saturday night. We did our orientation Sunday, and we started clinical work on Monday.
Were you ready?
So I think fortunately for us on the hospice wards, we had PAs, so physician's assistants, doing a lot of the ordering. Because I nothing personal, Amir, but I don't love your EMR very much, or the number of clicks it takes to kind of get things done. And so they were, pre-Epic transition. And it's not that I think Epic is very good, it's just the bad I'm used to. And so to walk into a new system, I think that would be really tough. So fortunately, the PAs have been there to really help us walk through orders. And initially they tried to geographically localize us as much as possible. And so that was really wonderful too.
So are you working with other UCSF colleagues, or are you guys sort of spread around?
So we're all working together, but we're taking care of patients on different floors.
Got it. So let me turn to Alex and Carly. So Alex, why don't you start and tell us a little bit about sort of what you heard that got you interested in this, and what needs you thought you'd be trying to fill by through the work that you and Carly and your colleagues started doing.
Mm-hmm. Thank you, Bob, for the opportunity to share our experiences. We're just so grateful at UCSF to have the opportunity to help patients and clinicians at New York Presbyterian. And we've learned a tremendous amount from this experience. And if we have time, I'd be happy to share some of those learning experiences. So much of what I've learned about what's going on at New York Presbyterian Columbia, where we're volunteering, which is in Manhattan on the Upper West Side, is from a podcast we did with Craig Blinderman, Shunichi Nakagawa, and Anna Berlin, who are the heads of palliative care at New York Presbyterian Columbia. And for those of you who don't know, I know you know this, Bob, Eric Wadera and I run a podcast called Jerry Pal, and we've done a series of about 15 podcasts on the impact of COVID-19 on geriatrics and palliative care, clinicians and services in hotspots like New York. We did one with Cynthia Pan at New York Presbyterian Queens, Mount Sinai, NYU, Boston, etc. So just to set the stage, New York Presbyterian Columbia, they have a relatively small palliative care service for a large hospital. They have 5 physicians, and their census pre-COVID was 20. And they described, as you said, Bob, they knew this tsunami was coming, and they could see like the waters recede before it happened. And then it hit, and it hit in 4 waves. The first wave was the emergency department calling them and saying, we need help now. We need a palliative care provider embedded in the emergency department to help us with these conversations with patients who are like, 90-year-old woman from a nursing home with dementia, no advance directive. Can you help talk to family members about what they might have wanted? We think they're COVID positive and they're headed for the ICU unless we hear otherwise. That was the first wave. The second wave was the ICU calling, right? ICU calling, these patients, patients doing very poorly, max ventilatory support, CVVH, pressors. Family says they want everything. Can you embed somebody in our ICU? We need a team dedicated to the ICU. This hospital went from, fewer than 100 ICU patients to 250, okay, at NYP. Columbia at its peak. Third wave was the hospital leadership asked the palliative care service to create an inpatient service for patients whose goals were exclusively focused on comfort, similar to our comfort care suites at Moffitt Long Hospital. They started with an 8-bed unit. I was on for 1 3-hour shift early on, and I could see the consults rolling in for referrals to their comfort care unit. 6 consults over a 3-hour period to move patients into that unit. And they only had 2 beds at the time. They since expanded to 14, then expanded from there.
And Alex, were these typically people who were already in the unit then leaving for comfort care, or were these people in the ED going directly there?
These are people who were in the hospital who'd had some sort of course, had transitioned to a comfort care approach, and they were looking to move them on to the comfort care unit that palliative care was primarily responsible for. So this is like palliative care caring for these patients, writing the orders, first call, and they had no such service before this. So they created this service out of whole cloth on the fly. The 4th wave, which we're in now, is helping patients who have been ventilated for, sometimes 4 weeks, right? And they're coming off the ventilator. They're starting to head towards discharge potentially to an LTAC, long-term acute care facility, which we don't have many of in Bay Area or California, but there are plenty of the rest of the country, and particularly in New York. And what's going to happen to these patients? And they're coming off and have diminished mental capacity compared to pre-COVID, or very poor mental status, diminished functional capacity. What does the future look like? And we're fortunate to have some information. There's a tremendous amount of uncertainty, right? Of course. But we're fortunate to have some information from Anil Makam, who's at San Francisco General, who studies LTACs. And Dr. Wadera actually read a quote from one of his articles. People who go to LTACs spend on average 66% of the remainder of their lives in an institutional setting, right? Whether it be a hospital, a nursing home, or an LTAC facility, so that we can give patients accurate prognosis about what happens. So palliative care service there went from a census of 20 to a census of 90 at its peak. And I think you're going to ask Carly about what we've done to help.
Turn to Carly, thank you. So Carly, it's all being done through telemedicine. So tell us about how that's all worked, and maybe put a little color commentary on how some of these conversations have gone.
Absolutely. Thanks, Bob. So we have a team of about 20 physicians. Most of us are from UCSF, and then we have a handful of colleagues from Stanford and Dartmouth who have joined us to do telehealth consults for the patients at New York Presbyterian. And as Alex mentioned, initially initially there was a huge wave of patients in the ED, and so we started off doing sort of shifts during their busiest times to address goals of care in an urgent way for patients who are coming in critically ill. And as time has gone on, there are fewer ER visits because New York has now passed its peak, and now there are around 200 patients who are still ventilated in various ICUs at New York Presbyterian, many of whom have been or will be ventilated for a prolonged period of time, like on the order of weeks, and for whom there's still some degree of uncertainty. And so to help with that, we are now doing longitudinal consults to follow patients for the duration of their hospitalization, since it's pretty hard to address goals of care in a meaningful way in shifts the way that we were initially. And we're currently following about 15 of the 60 consults that the New York Presbyterian team has at the moment. And I was just thinking, the talks before this were talking about all of this innovation, and I was just thinking that for us in palliative care, this is actually pretty core to our practice, that we do a lot of telemedicine on an outpatient basis. And even in our San Francisco hospitals, we've been doing telemedicine to talk with families because of visitor restrictions. And so while there are certainly some logistical and cultural and legal differences between our institutions, telehealth consults and having these conversations over time are really a core part of our palliative care practice, and it's gone pretty smoothly so far. The New York team has tended to send us some of their more complicated cases that are time intensive, because that's the way that we can be most helpful to them. And so we're usually in teams of 2 to provide continuity for the family members that we're talking to. And just as an example, so I did a consult earlier this week for a gentleman who's 67, who has Down syndrome and is deaf and has now been ventilated for coming up on a month. And his brother is his surrogate decision maker and is a physician himself. So you can really imagine that the brother knows and understands that the statistics for his brother are not encouraging, and yet the patient was pretty healthy before this, and so he's still really hoping for recovery. And by the brother's own admission, he's not there to see how critically ill the patient is, which really colors the way that he thinks about what comes next. And there's just this added layer of uncertainty that I think tends people to look toward optimism. Like we think, oh, this is a new disease process, maybe things will turn out better than we know they would for ARDS otherwise, for example. And so I think we're really trying to address goals of care as patients' clinical course evolves, which turns out to be much more of a roller coaster than I imagined it would be, and more so than it is for the patients that we usually take care of in the ICU, and then just really trying to help their families deal with that tremendous amount of uncertainty in what's already a really difficult situation.
Yeah. So just for our watchers, we're going to go to 1:40. We'll go another 8 or 9 minutes. Do the families you're talking to know you're in San Francisco?
They do. I use Doximity dialer, so when I call patients, I actually make it look like I'm calling from New York Presbyterian. Mm-hmm. But especially for this consult where the decision maker was a physician, I assumed that he was going to look me up on the internet afterwards, and so I preempted that confusion by just saying that I'm actually a palliative care physician in San Francisco helping the New York Presbyterian team. And I don't know about for you, Alex, I've said that for all of the families, and if anything, I think people have been really appreciative of our efforts to help out, and no one has said, oh, you're like not actually a part of my family member's care team. People have been totally open to that.
Yeah. And how do you kind of integrate into the flow there? Like, how does a patient get to you as opposed to someone who's on site? And how do you communicate with the patient's doctors who are taking care of them on site?
So their Epic actually has this amazing chat function. So somebody from their team will usually send us a text message and say, I have a new consult, are you able to take it? Because they of course know that this is not our day job. Yeah. And then we get on a chat that's connected to the patient's chart. And so they'll sort of give us the rundown. In the last couple of days, they actually started putting a picture of the patient in there so we can see them a little bit. And then we usually do a phone sign out and get in touch with the family and then touch base with the team by writing a note and then either calling them to tell them what we talked about or writing it up in the chat. The nice thing about the chat is that we can include all of the teams that are involved and sort of get everyone on the same page, and they send us updates that way too.
Right. Maybe come back to Amir, and then I'm going to sort of ask you all to close with kind of one thing that you're going to keep with you for the rest of your life from this experience. But Amir, and you're on mute right now. So we're talking a lot here about recovery, and as I think about what we have to recover from, it feels trivial. I mean, we had our maximum. We had about 20 patients in the hospital and 7 or 8 on ventilators, but we're still looking at a massive financial hole. and we have to sort of plow out of that. So how are you, as the caseload begins to go down, although it sounds like things are still pretty heavy there, how are you beginning to think about the future?
Yeah, Bob, I think the vision that we're trying to paint at this point is that we want to create a safe environment for our patients that come to New York Presbyterian Queens, and we need to make them feel comfortable that they're going to be safe in our environment in the hospital. And so everything that we are trying to do is all sort of planned according to sort of help us get to that vision, right? And so we have multiple groups across the hospital, some looking at, how can we get acute care started? Because interestingly, through this time, patients, we had a reduction, and as you've probably seen and read, big reduction in acute MIs, strokes, trauma.
We've all seen that everywhere.
Yeah.
It's remarkable.
Right. So we want to get acute care started. And then shortly thereafter, we want to make sure we can get all the urgent surgeries, patients with advanced cancer going. So whole group looking at that. Then we have a very large medical group. So, we have a whole team looking at the medical group and trying to figure out how to get all of that started. And then, as we've talked about in a lot of these conversations across the country, is that we've started to use so much telehealth, right? And we've all come up with some great ideas of how, things will look like in the future and how we've sort of dealt with this challenge. So we want to take some of the great ideas and lessons that we've learned and make sure that they're part of the new post-COVID era. Yeah. We're also focused on that. So I would say that all in all, our goal really is ultimately to create confidence for our patients to feel comfortable and safe, that they will be well taken care of, in our hospital. And that's sort of our vision that we've created around this post-COVID recovery.
Yeah. Alex, one thing you've learned that you're going to take with you going forward?
Yeah, so thank you, Bob. I've learned more. I feel like, people at NYP have been so grateful for our support, and we tell them we've learned more from this, right? We are getting probably more out of this than we're helping you. And one, couple of key points have come up. One is we can do this. We were very anxious about this at first, but when we got on the phone and started doing it, we realized, hey, this is bread and butter palliative care. You start with a relationship, right? You build a relationship. And after you have established that relationship, you talk about prognosis. And for some of these patients, it's talking about it in frank language, ICU clinician says they're dying. How do we care for them as we're dying? And then we set goals of care. And then we move on to a recommendation. So just getting back to basics and knowing that this is possible. This is a lesson that will endure. We can do remote palliative care consults from around the country to help each other out.
Right. Carly?
I would echo Alex's sentiments, and I don't know that this is necessarily a learning, but I think a thing that I will take from this is just that we really are all in it together. I think I feel that way as a person when I walk around and see that graffitied on the walls in San Francisco, but I think as a provider, it really is amazing how close I feel with the team in New York. And in Epic, other providers who know this patient or know his family member from other contexts will just send me a text message and say, I really appreciate that you're helping us out here. Can I help you? Is there backstory that I can provide? Do you need a friendly voice on the phone to call with you when you call this person back to have a hard conversation? Just the collaboration has been really, really rewarding and uplifting in what's otherwise a pretty suboptimal situation.
Yeah. And just to be clear, so it sounds like they do have Epic at New York Presbyterian in Manhattan and don't have it yet at Queens, which is how the situation Sanjay brought up.
Yeah, actually, we started on that journey in January. So believe it or not, they got into this. We may have just finished the implementation at Columbia when all of this started. Yeah. And Cornell is supposed to come next, and we're slated for next summer at Queens.
I'm guessing this slowed you down a little bit. Sanjay, any final lessons that you're going to take with you after this?
Yeah, definitely. And if it's okay for Bob for just 1 minute, a lot of people have asked how they can help New York. And I think I can dovetail this into the lessons. But I think the first one is, I think we should be hammering the government about protecting healthcare workers who are practicing during this time, particularly in such a litigious state. And so, it's awesome that people are clapping, but if you would instead reach out to government officials and tell them to protect the healthcare workers, that might be a better use of time. I think from a business standpoint, I think we should reach out to our tech companies and ask them if they can donate devices to hospitals and to underserved patients so that they can communicate with each other when they're isolated. Because one of the things that we've been surprised by is how many people don't have devices that they can do video chats with, even if we're at their bedside trying to do. And then I think the third is, especially with our palliative care colleagues here, pre-COVID, the one thing I knew about everybody on this call is that we're all going to die. And now in COVID, I think it just underscores that truth. And so let's really partner. I think this is a nice time for academics to be able to partner with community leaders and have these end-of-life talks with people while they're healthy. And I think part of the things that we could do as healthcare workers is describe our own choices and why. Because I think if we just tell people to talk about end of life, everybody's going to want to get everything done. And I think very few of us would actually choose that. I think in the case of COVID, I am DNR, DNI for sure. Even though we have people who are surviving, I would don't want to be out of bed for a few weeks. And so I think figuring out what our values are and have a responsible way of talking about end of life, the one known fact every human is going to face. I think this is probably the best time to do it. So however we can partner with our community leaders as an academic institute, I think this would be a beautiful time for us to be able to do that.
Great.
And then as part of that, I think realizing everybody that came to, it's been such a great group that came from San Francisco here, and realizing all of us kind of expect to get COVID. I think as we got to see the cherry blossoms in San Francisco that were in bloom, and then we get to see them here, and just kind of watching the petals like snow their leaves in the breeze, and knowing that in acupuncture a virus is called a wind invasion. I think there's this. I just pray that all of us can have such a beautiful death.
Thank you, Amir. I'll give you the last word. What are the lessons you're going to take with you, or anything else you want to tell this group?
I would say that, when a team comes together, there's no challenge you can't solve. And I think there's a power when there's collaboration and teamwork. And, through our major challenge here at the hospital, what I've noted is that it's brought, the chief of medicine and chief of surgery are best friends, okay? So Bob, it's amazing. It's just amazing. The intensivists in surgery and medicine, they're like brothers and sisters now. So, I think teamwork is what I take back. That I think an environment like this, when you're really thrown into a major challenge and crisis, which we have been in, it's brought people so much closer together. And there hasn't been one problem we have not been able to solve. Look, we can solve problems in a lot of ways, but I think that when the team came together, there was nothing we could not do. So I've learned that, teamwork is an amazing thing. So,
well, thank you all for doing this and doing what you're doing to take care of each other and take care of patients. And I have to say, this whole thing has been so terrible, but through it, there's been so much that I've seen, including what I've just heard in the last 45 minutes, that's inspiring and really awesome in many ways. So thank you all for what you're doing, and I wish you all great health and stay well, and hopefully we will get through this. We will continue to have these grand rounds every Thursday as long as there's a need to have them, and hopefully we'll be able to stop them sooner rather than later, but for now,
thanks for bringing us together, Bob. Thank you so much.
Yeah, thank you. Thanks for welcoming our people so well.
Amazing grand rounds today. Thank you.
Thanks, everybody. Be well.
You too.
Thank you very much.